Hey guys, so we just might get started. Okay, so my name is Sarah. I'm on the third years at Dandenong this year. So if you guys have any questions about like Dandenong or like SCS or Monash Health, I'm like more than happy to answer them after the lecture. So I'll be going through psych and behavior today. And my aim of the lecture is really just to summarize the curriculum so that you guys can just read my slides and just use it as revision, and then you guys can spend a lot more time on anatomy and physiology. Because the truth is that in the written paper, you don't have much weightage for psych, but the more important things is that your MSc can be a potential OSCE question, and he's like pharmacology is really important as well, because Richard loves like testing them. Okay. So we'll go through the mental state examination. I'm sure all of you know this. I'm not a big fan of mnemonics, so I don't really have a mnemonics. Just kind of like fall back on the principles of every single examination you do. So things like look, listen, and maybe not feel and psych, but more of like ask questions. So quite simply, general appearance and behavior, speech, affect, mood, thought, perception, connection, judgment, insight. I think it's really important that if you get a video in the OSCE and you're asked to report MSc, you need to cover every single one of these points. Okay, so we'll first talk a little bit about external appearance of patients and their behavior. So in your notes it says to talk about parent age. To be honest, I don't think it's really important to talk about it, and it can be a little bit offensive as well, because some people just tend to look a little bit older. You can talk a little bit about bute, and I personally think it's a really good one to talk about, because in patients with depression, it can go either way. They either binge eat and they have a lot of weight gain, or they lose their appetite and they became a little bit cacaxic. Dressing is a good one to talk about, so some buzzwordy things here. So if a patient is schizophrenic, they tend to be really messy, really unkempt. Patients with mania tend to be in like really showy colors, like flamboyant stuff. And depressed patients tend to be in like darker colors. Sometimes they can come in monochrome as well, but it's not the best telltale sign of their illness as well. Another thing I think is important to mention is whether they have any very typical appearance, like a Cushing-Knight appearance. Does anyone know what the Cushing-Knight appearance is?
Yes.
And do you want to just shout out what it is? Yeah. Yeah, so how does a patient with Cushing's look like? Yeah, well, okay, so really simply, have you guys heard of lemon on a stick? So so I've seen patients in hospital with Cushing-Knight syndrome, and they really look like a lemon on a stick. So they have really bloated face and a really big tummy, and their legs are really skinny. And females have things like hirsutism and acne as well. So it's a good one to mention in MSc because it shows that you're thinking. Because patients with a Cushing-Knight appearance tend to be on steroids, and I think it's really important. I think the most important thing Monash wants you to take it from psych at year 2 is that a lot of common conditions have psych implications because of the chronicity of them. So patients with things like Parkinson's and all that can have long-term psych issues like depression, or patients with endocrinological issues can have a lot of psych issues as well. It's important to draw the links in them. Okay, so moving on, we have things like gait. So depressed people are slow, really slumped, they drag their feet and stuff. Motor activity, neurological signs. So in patients with Parkinson's, you have your typical resting tremor. Sometimes they call it pin rolling of your thumb, and it's basically just like this. You can also see evidence of a recent stroke. So some patients come in looking really their hands are kind of extended, and they kind of have a circumferential gait. You can have cerebellar problems as well, so patients who are ataxic and they have a wide, broad-based gait, psychomotor agitation and retardation, but again, that's not really obvious until you start interacting with the patient a little bit more. And I grouped the last 3 together because I think they're a little bit interchangeable, so things like social manner, response to interviewer, as well as nonverbal communications, like whether they're really fidgety, whether they're really restless. And some patients tend to be a little bit more defensive if they're feeling anxious, and they can also be pacing around. That's the other end of the spectrum. So in terms of speech, just go for the really simple things. Are you speaking in English? Is it easily understood? Is it clear? Quantity of speech is a little bit iffy because I feel it's easy to mix up quantity of speech with quantity of thought. Sometimes patients can just seem to be speaking real little, but it's because they have poverty of thought, and therefore they're not really talking as much because they can't think through as quickly. We've also got style and modulation, so whether they're really monotonous and whether it's mood congruent or incongruent. So sometimes patients who are depressed tend to speak really softly, but if a patient is depressed and they're yelling at you, then you might think it's a little bit different. So mood and affect, I think it's really important to be able to show the examiner that you know the difference between mood and affect. So mood is essentially what the patient says when you ask them directly how they're feeling. So what I thought some of the juniors was to just report it saying like, oh, the patient describes his or her emotions as, and you just directly quote whatever the patient says. Because then it kind of shows that you know the difference. Whereas affect is pretty much what you think the patient is feeling based on your observations. One thing I wanted to point out is that it's important to ask the patient both how he's feeling today as well as to describe their emotions in the past week, because the patient might not be feeling particularly depressed during the interview if there's a new reason for them to feel otherwise. So the patient's current mood is not entirely reflective of the entire state of mind. Under affect, few things to talk about as well. So of the 5, I would say the most important ones are range, reactivity, and appropriateness. So you guys know like all of them, right? Okay. So like reactivity is basically a normal reaction to a situation. So like for example, depressed patients don't smile when they talk about nice things like cakes and like family. And appropriateness is whether the patient's emotional state is pretty much linked to his or her current circumstances. So if someone has recently lost a job, recently, like lost his or her like family member and is diagnosed with cancer and is depressed, it's pretty appropriate to his or her circumstances. And modulation is like whether the patient seems to genuinely be feeling how he or she says he or she is feeling. But again, it's okay if you don't mention it. So we move on to intensity and range of affect. So I think the easiest way to think about it is to look at the pictures. So a patient, so let's say you can only experience 7 emotions in your life, let's say, and like you experience each emotion on a scale of 0 to 10. So a patient with a restricted intensity of affect can experience all 7 emotions, but instead of being able to experience each emotion from 0 to 10, they can only experience them from like 0 to 5, 0 to 6. So you don't have the full range of like feeling like the intensity of the emotion. Whereas a restricted range of affect is instead of being able to feel 7 emotions, the patient can only feel 5 emotions, and the patient completely doesn't feel like the other 2 emotions at all. Okay? So for thought, 3 things. So firstly, stream, how fast the patient talks. So again, important to know the difference between increased stream and pressured speech. So it's a little bit weird because it's like increased thought stream but pressured speech, but it's under thought. Yeah. So pressured speech is not interruptible, so the patient basically just keeps talking and talking and talking, and you can't stop the patient to clarify something at all. Form, so 3 things: formal thought disorders, flight of ideas, as well as poverty of ideas. And content, so overall content of the patient's thoughts, whether the patient is preoccupied over something, any delusions, overvalued ideas and obsessions as well. So thought form. So firstly, flight of ideas. I just kind of put it here, but it should be on a slide of its own. But just know that flight of ideas is basically when the patient has normal words and sentences, but the connections between them are really fast and you can't usually keep up. And usually patients with flight of ideas tend to have really rapid and pressured speech. So formal thought disorders are the ones in red. Yep, okay, so I recently thought of an analogy. So tangentially, you guys know like tangent, like math. So like, you know how like the graph just kind of goes all the way up? So it's the same thing. So the patient starts at a point and the patient just keeps going off topic and doesn't get back to the point. Whereas for like I think it's circumferentiality. I kind of spelled it wrongly. But it's basically when you start at a point and the patient goes in one circle and then gets back to like the point. So you kind of like beat around the bush, but eventually the patient answers your question. Yeah, so just ignore that. It's like a typo. And then we've got derailment as well, which is when there's like a poor logical connection between ideas. So like if you break the patient's words down, each phrase makes sense, but when you put it together, it doesn't make sense at all. And there's thought blocking as well, which is when the patient like starts talking and all of a sudden just stops talking and just like a sudden break in flow of thought. Okay, and just wanted to say that derailment is usually related to things like euphoria as well as hysteria and bipolar disorder as well, and that can happen in tangentiality as well. And just the ones in black are things that are good to know, but I don't think are very common. So neologisms are things like inventing new words and phrases, which kind of sucks if you have like limited vocabulary, because sometimes patients just like know a lot of words and you don't know them. But yeah, usually you make it really obvious. So thought content, so buzzwords for delusions, fixed false beliefs. I think the lecturer kind of drilled into us last year that you just need to ask yourself these 3 questions. Firstly, is it possible? Is it likely? And does it make sense in this case? And if the answer is no to like any of the 3 questions, a delusion is likely. You've also got overvalued ideas, which are unreasonable beliefs that can be challenged. So if you like constantly ask the patient like, oh, do you think this is possible? Or you offer the patient like alternative suggestions, the patient can actually be swayed to believe otherwise. Preoccupations, when the patient's conversation just pretty much is on the same thing the whole way through. We've also got obsessions and compulsions. Do you guys know the difference between them? Obsessions and compulsions? Okay, so obsessions are basically thoughts, whereas compulsions are actions, like you having to perform the actions to get the thought out of your head. So like, you know how they always talk about like OCD, which is like obsessive compulsive disorder? So not all patients with OCD actually have OCD. Some of them are just really obsessive and some of them are just compulsive. But usually if they are compulsive, they're obsessive as well. And we've got phobias and suicidal ideations as well. I think like Electra gives you like this table where they summarize like all the phobias. You guys don't have to know that for exams. But one thing I like to point out is that suicidal ideations are really important to note whenever you're watching an MSE, to say whether the patient has any active suicidal ideations, and if the patient has brought up suicidal ideations in the past, mention that you like to further investigate if the patient has any further thoughts about committing suicide, and what their plans are when, like, you know, they start thinking about suicide. So perception is really important. So you need to know the difference between illusions, hallucinations, and misinterpretations. So illusions, the easiest way to think about it is optical illusions, like the things that you think you see one thing and then if you look carefully it's something else. So they can be corrected based on an object that's present. Hallucinations usually cannot be corrected and they can affect all senses, so auditory, visual, as well as smell. Misinterpretation cannot be corrected, but there's usually an object present, and the most common thing is dementia, where you misidentify your family members as well. And then there's this really nice table in your slides that I think helps you understand it a little bit better. So note that all delusions are related to thought because you kind of originate from the patient's own thinking inside the head, whereas perceptive disorders, on the other hand, require sensory input as a trigger. So cognition, I'll talk about this a little bit later. Usually you assess it using the MNSE. Less than 25 means that the patient is at risk. So usually you ask the patient whether he or she is oriented to time, place, and person, and you guys know how to do this for like your gastro exams as well. So you quite simply just ask the patient just a couple of silly questions. Do you know where you are today? Do you know what day it is? And what is your name? Okay, so remember to ask that for gastro, because like you can get that in like hepatic encephalopathy, and the person is like disoriented as well. Yeah, and sometimes if like an elderly patient is disoriented, you start to think of things like delirium and dementia, and I'll go through that a little bit later. Oh, and usually in the video, they don't assess the patient's cognition. So something you might want to say is that the patient's cognition was not formally assessed in this video, and I like to do so using an MNSE, and then it makes you sound a lot more eloquent and shows that you have thought about it. So for judgment and insight, so judgment is the ability to behave appropriately in a given circumstance. You just show the patient a really simple question, like, what would you do if your kitchen's on fire? I think they teach you to ask, like, what would you do if you saw, like, envelope with money on the floor? Do they still teach you that? Because they've, like, told us to ask that last year, but then when my friend, like, kind of practiced and asked me that, I gave the wrong answer. So then I feel like it's not a very accurate question to gauge a person's judgment on. So I'd usually just go for something a lot more obvious, like, what would you do if your kitchen's on fire? And like, a sensible person would tell that, you know, they'll get out of the house and they'll call, like, the fire brigade or something. So for insight, basically just a couple of questions to ask yourself. So one, whether the patient knows that he or she has a mental condition. Two, whether the patient knows why he or she is sick. And thirdly, if the patient actually wants to actively get better. So if it's a yes to all 3 questions, the patient has good insight. If it's a yes to only about 2 of the questions, the patient has moderate insight to his or her condition. So a couple of questions. Lyndon's an aspiring architect. However, when she tries to draw rectangles and tables, the shapes always end up looking like triangles. So what does she have? Anyone just want to shout out? Is she really? Yeah, really good. So it's A. Second question. Anyone just want to? D? D? Yeah, good. And more questions. So these questions may or may not have been adapted from past year questions or like revision lectures. So Sorry? Does anyone know the answer to this question? Sorry? Yeah, B. Yeah, so like flexibilitating is not a real word. So it's A. Okay. Okay, next question, guys. Delusions? Did you say delusions?
Yes.
Okay, yes. Do you guys know why?
Because it's not possible, likely, or the other one.
Yeah, and she's convinced, so like you can't actually correct her opinion on it. Yeah. This one was a question that the lecturer asked, like during his lecture, and then I think he gave it to us for exam as well. So I'll just give it to you. The answer is normal, because like she's a 6-year-old girl. It's fine for her to have an imaginary friend, and it's okay that she confides in her imaginary friend because of her age group. So the answer is B. So, okay, so I have some, if you guys read like the pre-lecture slides, I have a couple of spiels in there that you guys can just like read and rattle through your MSEs, but we just go through like each one carefully. So if a patient is depressed, we'll just start from here, and then you guys can just shout things that you think a depressed person would come in with. So, yeah, you can start. Okay, we'll start with like general appearance and behavior. Yeah. Yep. Yep. Yeah. Really good. Speech. Mm-hmm. Yep. So I think that's a little bit more to do with like response to interviewer. Like I would pretty much put it there. But yeah, that's a really good point. Affect and mood. Yep. What about their like range and intensity?
Restricted and probably
Yep. Yep. Okay. And like their mood will probably be depressed. Like they'll tell you like, oh, I feel really sad and stuff. So thought? Yeah. Okay. More? Yep. And what would you ask for if the patient has suicidal ideations? Maybe not so much plans for the future, but like whether they have any like active suicidal thoughts. Yep. And like what they would do. So like will they like call the hotline, or will they tell a friend when they feel like, you know, like suicidal and stuff? Yep. And will they have any form of thought disorders? They can, but it's unlikely. Yep. Perception? Yeah, that's good. Cognition. Yeah, so you usually just say that it's not formally assessed using an MMSE. Okay. Judgment and insight. Mm-hmm. Okay, really good. Oh, you guys know your stuff. Okay, so I've got a spiel over here. So what, because you know like how I started the lecture, I was telling you guys that like some conditions are linked to psych conditions more than others. So patients with Parkinson's tend to come in with depression, and like if in your exam there's like, you know, they talk about a Parkinsonian patient and they ask you what's the most likely psychological illness they have, the answer is depression, okay? So I highlighted the things that are a little bit more suggestive of depression. So things like a cachectic appearance, the patient could be anorexic, messy clothing, unkempt hair, shuffling gait, and resting tremor are a little bit more suggestive of Parkinson's. So mask-like appearance, the thing is some patients with depression can just look really like blank out, but just bear in mind that patients with Parkinson's will have a mask-like appearance, and it may or may not be due to depression. It's usually more often than not due to the fact that they're taking antipsychotics, and they're a little bit sluggish as well. Again, having monotonous speech is an overlap between patients with Parkinson's and depressed patients, again due to Parkinsonian drugs. Affect was depressed, range of moods to reduce. Yeah, so you guys can just read this on your own. I missed out on connection and judgment here, just because like usually you don't see it during the video. Okay, so I'll talk a little bit about depression. Have you guys heard of the DSM-5 diagnostic criteria? Yep, so you guys don't actually need to know this for your exams. So I just put it in here just for like completeness sake. But in case someone just ever asks you, just know that it's one of the top two or four or more of the bottom. It's not an N, it's an O. And yeah, you don't have to remember this for your exam, so just don't worry about it. But you guys need to know the pathophys of it. So in depression, that's a postulation that is due to upregulation of monoamine receptors. And you also need to know the treatment. So with OSCEs and with everything, when you are asked to talk about treatment, always go like stepwise. So always start from non-pharmacological things. So start with like psychological things like your essence, your HEP stuff. So like CBT, counseling, and mindfulness. And then for pharmacological, your first line is your SSRI, which is your selective serotonin reuptake inhibitors. So things like citalopram and sertraline. And if there's a failure to respond, you consider things like your TCAs, which are your tricyclic antidepressants, which is your amitriptyline. And beware your anticholinergic side effects. So do you guys remember what sludge is? Yes? Okay. So like anticholinergic is basically just anti-sludge. Take note that antidepressant drugs will act by elevating your monoamine levels, which then downregulate your monoamine receptors, and this takes about 14 days to work. So depressed patients usually tell you like, oh, my drug's not working, but it's really just because they need to wait 2 weeks before they start to feel the effects of it. So I have like a table here. I just kind of put the class of drug, and then the ones in red are the core drugs that you guys need to know. The ones in black are the ones that they like to trick you with, but yeah, they're the same class. And then I talked a little bit about mechanism of action and side effects as well. I think like for drugs, it's pretty much self-explanatory. You just need to just study them and just know the more common ones. There isn't really a way around it. And Pedro is giving you guys a psych lecture, and he's really good with like a pharm lecture. He's really good with his pharm. So yeah, just know that like TCAs also block your M1 receptors, and therefore it can cause cardiac arrhythmias. Does anyone know why? Do you guys know why like blocking your M1 receptors will give you cardiac arrhythmias? You guys need to know this for your bias. Yeah, really good. So it's because you block the vagal inhibition of your heart. You also have your H1 and A1 receptors that are blocked by your TCAs as well. So your TCAs are generally not really preferred because there are a lot of side effects. Depression is an indication. If I put a CI before it, it means it's a contraindication. Okay, so your first line drugs for depression are your SSRIs, which specifically block your reuptake of your serotonin receptors, giving rise to increased levels of serotonin at your synapse. So increased serotonin release in combination with increased synaptic transmission will ultimately result in like a downregulation of your postsynaptic serotonin receptors. Just take note of like overdose or serotonin syndrome. It's classified by things like agitation, confusion, hyperreflexia, sweating, shivering, tremors, as well as diarrhea and fever. It's contraindicated in St. John's wort, and because it causes bleeding and PUD. Do you guys know what PUD is? Yeah, peptic ulcer disease. So what is one other kind of drug that causes peptic ulcer disease as well? Yeah, NSAIDs, okay. And yeah, so you usually try not to use it with other like MAO inhibitors as well as TCAs, because polypharmacy can actually trigger a lot of things as well. So I just put here like the other kind of antidepressants that Richard wanted you guys to know. So reversible and irreversible MAOIs. Again, just go back and like read through this. They tested us on like sexual dysfunction last year for like this one. I can't see it, but yeah. So just remember like irreversible MAOI side effects, sexual dysfunction, and also know about the cheese reaction. So these are just all really buzzwordy things. Just like remember them. Don't waste your time. So now Parkinson's disease. I think someone will go through like Parkinson's with you in a lot more detail, but in a nutshell, if you really can't remember anything, just know that it's due to a loss of neurons in your substantia nigra, and it's associated with reduced levels of dopamine. So causes, I like to break things down. So idiopathic, otherwise known as primary causes of Parkinson's disease, is due to genetic causes. You've got secondary things like drugs, trauma, post-encephalitis, as well as infections. So buzzwords for exams: Lewy bodies, microscopic nigropellae, and these are just some of like the signs and symptoms that the patient can come in with. And you guys need to know your anti-Parkinsonian drugs. So know that there is no cure for Parkinson's disease. Again, as with all other things, I know I'm really naggy, but always start with like non-pharmacological treatment, so things like multidisciplinary rehab. And for pharmacological management, so the main drug you need to know is levodopa. And levodopa is usually combined with a DDCI, which is a dopamine decarboxylase inhibitor, which is carbidopa in this case. So how it works is that DDC basically converts dopa to dopamine in your CNS once it has crossed your blood-brain barrier. And the problem is that like dopa can also be converted to dopamine in your peripheral nervous system. And that's not really ideal because if there's too much dopamine in your peripheral nervous system, you can kind of get like all your unwanted things like your dyskinesia, you get like really irritable as well. So you want to administer it with a DDC inhibitor to increase the availability of dopamine in your CNS. Does that make sense to you guys? Yeah, so just remember that it just can't cross the blood-brain barrier, and you don't want dopa to be converted to dopamine peripherally. So you need to protect it and leave it to your CNS to be changed into dopamine. Okay? You guys also need to know Selagilin. Yeah, I think that came out for us last year as well. So anxiety, we'll start from this side. So just some things that you might notice in a patient with anxiety. Yeah.
Like feeling nervous, like all eye contact.
Mhm. Yeah, so they can be like really unkempt as well. Yep. Speech.
So I played it if it could be fast or if there actually could be like sudden alert or something like that.
Mhm. Good. Affect.
Anxious.
And it will be like anxious as well. Thought. Mhm. So usually patients with anxiety they can have like circumferential thought just because like they just like get distracted and then you just go in one round. They tend to have delusions as well. Usually persecutory delusions, and they feel like someone's just constantly nagging at them. Sometimes they can have like OCD as well, so like obsessive compulsive disorder, or you might want to break it down and say the patient has obsessions, the patient is preoccupied over this subject as well. Yep. Okay, perception. Yeah, so it's usually quite unlikely. And the last three.
So with cognition, MMSE.
Yeah, perfect.
Judgment, I would assume they would have normal judgment, it's just that.
Come on, go.
And with insight, they may or may not be aware of how much the anxiety is affecting them, so they can
Yeah, okay, that's really good. So, again, a spiel. You guys want to read this on your own? But, okay, so just know Graves' disease is linked to anxiety as well. And on the other hand, hypothyroidism can be linked to depression as well. So if, like, it's not Parkinson's, it's hypothyroidism. So Graves' disease, pop quiz. So, like, what are some signs and symptoms of a patient with Graves' disease? Just, like, shout out.
Anxiety.
Anxiety, really good. Okay, more? Sorry? Yeah, you can get that. Yep. So usually how I like to group in OSCE is I like to say that patients, I'm looking for signs of thyroid ophthalmopathy in patients with Graves' disease, because usually the eye signs in thyroid are what distinguishes Graves' disease from like hypothyroidic patients. So yeah, just some things to note. Yeah, so proptosis of her eyes is a good one, and the fact that she has a goiter in her neck as well can also indicate that she might have Graves' disease. And yeah, so nothing else I want to point out here. Okay. So anxiety. So anxiety is a normal emotion experienced by everyone. It becomes pathological only when the fear is greatly out of proportion to the risk and severity of threat. In terms of like generalized anxiety disorder, again, some buzzwords. So it's pervasive, it's excessive, it's also uncontrollable. It's usually linked with like restlessness and feeling really tired all the time. You can't really concentrate doing work as well. You tend to be a lot more irritable. So it's really, if you think about it, it's a lot like the systems review that you ask for Graves' disease and hypothyroidism. I feel like the two are really linked. So if you just blank out, just think back on like hypothyroidism. And types of anxiety disorders, so you've got your phobias here, and you've also got your panic disorders that are characterized by physical symptoms. So what are some physical symptoms they might have? Signs, I mean.
palpitations.
Yeah. Okay, so they're at risk of getting AF as well, atrial fibrillation. I wanted to talk, okay, so sleep disturbance. So usually patients will come in complaining of like restless, unsatisfying sleep. So schizophrenia, just anyone just wants to start? Yeah, you can start.
They might have like a messy, like not look after their clothes.
Mm-hmm. Speech.
So they might have rejection speech,
Mm-hmm.
potentially impulsive disorder.
Yep, so affect and mood, it depends on the patient. So usually schizo patients can sometimes be like really happy, sometimes they're like really depressed. It really just all depends on the interview. They usually do have some sort of form of thought disorder. Perceptions, they tend to have hallucinations, so it can usually be like, it's usually auditory or visual, and they tell you like, oh, I hear 3 voices, and stuff like that. Yep. And cognition, judgment, and insight are usually quite impaired in patients with schizophrenia. So again, I couldn't really think of a condition that's linked to schizophrenia, but just some like important things. So they usually have like neologisms, like they make up like random words, and they also have delusions. And like I mentioned, they usually have auditory hallucinations as well. So note that if schizophrenic patients have neurological abnormalities, it tends to be more because of the antipsychotic medications rather than the illness itself. And patients with schizophrenia tend to get sensory deficits more than motor-like signs. Okay, so for what you need to know, so just note that it's a psychosis lasting for more than 6 months, and it causes a significant disruption in function. So usually it's more of like being able to attend social situations and like, being able to interact with your friends and stuff. And it's not attributable to substance use. So usually they're not people who has been taking like drugs, and they're not IVD use as well. In terms of like the genetic predisposition, just note that there's a 40% concordance in like monozygotic twins, and a lower percentage, so like 10 to 20% in dizygotic twins as well. So the etiology may usually be drug related, but it usually rises from cocaine or amphetamine overdose as well. But again, just remember that it's not attributable to substance use. So the line can be quite fine there, like trying to differentiate whether the patient actually has schizo and therefore taking the drugs, or is taking the drugs and also has schizo. Yep. And in terms of symptoms, I think it was emphasized last year to basically characterize them into positive symptoms, so things that added onto you, so like delusions and hallucinations, and negative things, so normal things that you normally would do but can't do anymore, so things like blunting of emotions as well as having a flat affect. I think it's important to know the pathways because they ask you quite a few questions during your exams. So just know that there's like a mesolimbic pathway that's more important for your behavioral stuff. Your nigrostriatal pathway is to do with movement and flight control. I just kind of remember it as like your Parkinson's disease pathway. And then you've got your tuberohypophyseal pathway, which is to do with your dopamine and prolactin. So these are your antipsychotic drugs. Given the pathophys behind schizophrenia mainly lying in the dopamine hypothesis, so antipsychotic drugs are mostly dopamine receptor antagonists. So again, just remember that your mesolimbic pathway is responsible for psychomotor slowing as well as emotional quieting and aggression. So I think the most important drug to know on this slide is chlorpromazine, which is most sedating. It's also most potent. And it also blocks your H1, A1, and M1 receptors as well. So which drug causes hypotension? Over here.
Chlorpromazine.
Yep, and why is that?
Because of the
Yeah, that's really good. Do you guys all hear that? So chlorpromazine will cause hypotension because it blocks your A1 receptors. Okay? Yeah. Does that make sense? No? Yes, no? So do you guys know like the difference between your alpha receptors, your like muscarinic receptors and all that? Sort of? Forgot? Okay, so I think it's really important to know like the difference between all your receptors, because when you block different receptors, you tend to get different side effects, and if you remember one or the other, it'll help you during exams. So I think just know that like for alpha receptors, they're responsible for things like for blood pressure regulation. So once they're blocked off, the patient can't regulate the blood pressure as well, and therefore they get hypotension. and it's sedating because it blocks off your H1 receptors. Okay. Some side effects as well. So weight gain is a pertinent one. It's important. And in terms of indications, it treats mainly your positive symptoms of schizophrenia, so your delusions and auditory hallucinations. It doesn't really treat the negative things like social withdrawal as well as blunting of your affect. Good ones to know over here are quetiapine. Risperidone is commonly used in hospitals next year. So when you guys go into wards, you see that a lot of patients are either on quetiapine or risperidone. And yeah, so this was what I was talking about, like your receptor blockade, your D2 alpha, H1, and your serotonin receptors. He doesn't really test much on them, but I think it's just good to know. It helps you with your understanding. Yeah.
Sarah?
Yeah.
So with chlorpromazine, why does it cause potent anticholinergic effects?
With chlorpromazine,
Yeah.
because it blocks like your muscarinic receptors as well. Yeah.
Okay.
Okay. So this is not likely to come on your OSCEs, but it's a really common situation in the wards. So just have a quick read through and somebody just yell out the most likely diagnosis for this patient. Any ideas? No? Okay, so the patient has delirium. Like, you know how they always talk about delirious patients on the wards? Yeah, so usually the patient is irritated, really like confused, and like being like a nuisance to the nurses. So the nurses just want to sedate them, but you can't do that because it's illegal. So we've got delirium dementia. I can't remember when he discussed this, but like, because I want to talk about like your sedatives and your general anesthesia, so I just like kind of put this in as well. So just know the difference that delirium is basically quite acute. It's an acute change in mental state because of an underlying pathology. So usually an acute illness can be something really simple like a UTI or like pneumonia as well. But because the patient is usually elderly, it kind of just tips them over and they get really like irritated, and like sometimes the patient can like swing the other way, and instead of being like really noisy and really like irritating, the patient can be really quiet as well. And this is called hyperactive delirium, and usually these patients are missed on the wards. Okay, and dementia is basically like a chronic thing, and yeah, just know that like the different ones like Alzheimer's, vascular dementia, dementia of Lewy bodies. But again, I don't think this is likely to come on your exams. Okay, so sedatives. Important ones to know are diazepam. Temazepam is not really used. Yeah, I haven't really seen temazepam being used in the ward, so I mostly see diazepam. So GABA basically works to inhibit cell neuron activity in the CNS and therefore reduces your anxiety and aggression as well. And it also induces sleep, so usually that's like a sedating effect to do together with the drugs. Note that benzos actually cannot directly activate the GABA receptor, but instead they actually modulate the activity of GABA. So it's kind of like an indirect pathway thing. Okay, so I put here the half-life, so which one is long-acting? Diazepam is long-acting. So it usually lasts for like 24 to 48 hours, and temazepam lasts about 12 to 18 hours as well. Okay, so for general anesthesia, yeah, so I put here like, because I think last year they gave us like some scenarios and they were like which GA is most likely used or something like that. So just know like different indications. So I think the ones that I point out are ketamine and propofol. So note that sometimes they can be used as analgesics as well. So patients that are in some pain, sometimes the anesthetist will give them ketamine, propofol, and it has the side effect of sedation on them. Okay. So GA, general anesthesia, can either be inhaled, so things like your nitrous oxide, halothane, or it can be like, you know, it's like IV as well through a bung. Ceiling effect over here basically refers to the dose beyond which there is no additional effect. And induction of the drug over here depends on solubility of the drug, okay? And I put here like when ketamine is used, when propofol is used and stuff. Okay, so seizures and epilepsy. It's not very examinable in second year, but what's important to know is your anti-epileptic drugs. So loosely you can think of seizure as like a clinical symptom. So without looking at the thing, do you guys know the difference between epilepsy and seizure? So when does a seizure become epilepsy? Okay, you guys are all looking at the thing. So like epilepsy is when a patient has 2 or more recurrent unprovoked seizures. So I just wanted to clarify, because we just had a lecture on it like last week, and I don't have time to like change the slides. But basically an unprovoked seizure is basically a spontaneous seizure with no obvious reversible factor. So I'll resend the slides, because like there's like some errors over there. And basically seizures are caused by things that, unprovoked seizures are further classified into symptomatic and asymptomatic seizures, but you guys don't need to know that. Just know that there's a difference between seizure and epilepsy, and you guys need to know that there are different types of seizures. So there are like generalized seizures and partial seizures as well. So do you guys know the difference between generalized and partial seizures? So which one involves the entire cortex? Yep. And can a partial seizure become a generalized seizure? Okay, good. And what's the difference between a simple partial and simple partial seizure and a complex partial seizure? No, so a partial seizure affects only one part of your entire brain. A generalized seizure affects all parts. So there are different types of partial seizures. So you can have simple partial seizures and complex partial seizures. So the difference between them is that simple partial seizures don't involve any change in conscious state, whereas complex partial seizures, the patient usually gets a little bit groggy or like can totally blank out at some point in time. Okay, so I know it's a little bit confusing, but yeah. And do you guys learn about petite mal seizures? Yeah, so don't ever say that on the wards. Like the cons will be like, what are you talking about? So the new name for them is absent seizures. And just know there's 3 Hz spike plus slow wave on EEG. If you see that, it's an absent seizure in an exam. Anti-epileptic drugs. So if let's say a patient comes in and has a seizure, your acute management is basically to let the patient seize for 1 minute. So you don't intervene at all until the patient starts seizing for 2 minutes. You want to clear things away from the patient and also put the patient into your left lateral position, which is also your recovery position when you're doing like basic life support for the patient. It's important to talk about driving with the patient. This can come up for your OSCEs. So like private drivers must not have had seizures in the past 12 months, and commercial drivers must not have had seizures in the past 10 years. So it's quite a big difference over there. So it's not too important to know your mechanism of actions of these drugs. Just know that like absent seizures are treated with ethosuximide, and in general, phenytoin is more of a second-line treatment, and you don't really use it for first-line treatment anymore. The important thing to know about phenytoin is that it causes gum hyperplasia, acne, as well as hirsutism, and this always comes out in the exams, so just know that. Oh, and for ethosuximide, you can also have pancytopenia as well as agranulocytosis as well. Yeah, so buzzwords. So more questions? What is the answer for this? Okay, so the answer is A. So if the drug is less soluble, there's a faster induction time. So it's a little bit counterintuitive. So remember how I was talking about inhaled general anesthetics and things like nitrous oxide? So nitrous oxide is the least soluble and therefore the fastest. MAC over here, minimum alveolar concentration ratio, is a measure of potency. And other factors that determine the speed of onset that can come up for your MCQs are like cardiac output. So if a person's cardiac output is increased, do you think the anesthetic uptake to blood is faster or slower? So is induction faster or slower? Oh, it's actually slower. It's actually the opposite. Because like when your cardiac output increases, your anesthetic uptake to your blood increases, and therefore like just because of like pathophys, your alveolar gas concentration decreases. So it's actually the opposite. Yeah. And alveolar ventilation as well, so the rate that you're breathing, if the patient is breathing a lot faster, there's increasing uptake and you get faster induction as well. So again, another question that's important to know. The answer is C. Everyone got that? C? Okay. And this one? A. Yep. So, sorry, I'm just kind of like smashing through because I don't have much time. So we've got your mini mental state examination. If you get it from an OSCE, you should be really happy because it's just a piece of paper. You just need to like fill it up. There's nothing much for me to go through really. You just need to know that it exists, and it's a screening test, but it's not diagnostic. And it mainly assesses your temporal lobe function. So I think Mendel will go through neuroanatomy with you guys, but just know that it's really important to know all the functions of the lobes. So specifically for psych, most of your behavioral and executive functions are in your frontal lobe. So I put here things that your MMSE tests. So for example, like drawing a clock face tests your frontal lobe function. Temporal lobe function is like you test it with your immediate recall, your short-term recall, as well as long-term memory. And your parietal lobe function is tested by your CO7s. So CO7s also test your working attention. Yep. I just learned it today as well because the lecturer just said it. Okay. So yeah, I don't have anything to value add for like attention versus concentration. It's always the same question every year. Just know that attention is reactive and concentration is like active. Yep. So more questions. So Phil presents with difficulty speaking. His wife reports that he's become more impulsive and disinhibited lately. On examination, he has difficulty with fine motor control. So which lobe was most likely affected? D. Yep. Does everyone know why? Okay, so when the patient presents with difficulty speaking, what kind of aphasia is it? Yeah, so it's Broca's aphasia, and if the patient has difficulty understanding you, okay. So why it's frontal is because Broca's is in your inferior frontal gyrus of your left hemisphere, and your frontal cortex also contains your premotor cortex, which is responsible for fine motor control as well. So if you get a frontal lobe lesion, other things Phil can present with is like contralateral hemianopia, as well as partial seizures. So why is it not like occipital or parietal? So what happens if a patient has a parietal lesion? Yep, so usually you get like your constructional apraxia, partial seizures, contralateral hemisensory loss as well. With your left temporal, so between the left and the right temporal, which lobe will give you Wernicke's aphasia? The left? Yeah, because it's a dominant one. And also something to note is that if you have a lesion in your left temporal lobe, you can also get contralateral homonymous superior chondrotonopia, which is like your pie in the sky thing. You guys learn that? Yeah, okay, just tip, you guys really need to know like your optic lesions, because like they always ask questions on that during the AMQs. So left temporal can give you a contralateral homonymous, so it's on the same side, superior, like on top, and quadrantonopia, which means like only a quarter of the entire visual field is lost. Yep. So I thought I'd talk a little bit about the approach of psych history. So not all patients come with an obvious psych problem. So most of the time they come in with a really general like symptom like fatigue, feeling out of it, stressed and anxious. So importantly, I think it's really good to just go through all your relevant system reviews. And psych history is important, but it's really not your top differential most of the time. And it's only when the patient starts denying the common symptoms that you start to think, maybe it's a psych issue and stuff. And like vice versa, psych conditions can be a cause for common symptoms. So chest pain can be caused by anxiety and panic disorder as well. So this was in your clinical skills book. So make sure that you guys know how to approach like a fatigued OSCE really, really well, because it's very common and it's quite likely to come up for your OSCEs. So in CVS, I'll just quickly go through things like your heart failure can give you fatigue, chronic lung disease. So blood loss, what's IDA? That's IBD. Yeah, so IDA is iron deficiency anemia. And what kind of anemia is iron deficiency anemia? Yeah, so it's a normocytic anemia. Sorry, I'm just like quizzing you guys as I go. Endocrine stuff like hypothyroidism, DM, diabetes, room things. You guys know what SLE is? Lupus, yep. Neurological things like myasthenic gravis, infections, recent stresses, and the big red flag you don't want to miss is malignancy. So what are the questions you ask when you suspect a patient has cancer? Yeah, so whether how much weight loss, Over how long? Is it intentional or is it not intentional? Okay, so pinpointing in psych history is, let's say you've decided that the patient has a psych problem. Questions you want to ask are things about like recent events, past events, similar episodes in the past, whether the patient has previously had a psychiatric condition, how people around him or her are feeling and coping, mood changes, sleep pattern, diet, lifestyle. And like I said, specifically about hallucinations, delusions, suicide, and self-harm. So last year I thought it was really hard to just kind of like ask the patient, but I figured that you just need to be direct. Just let the patient know that it might be a sensitive issue, but you just have to ask it. And you just ask them directly, have you ever thought about committing suicide or killing yourself? Okay? Yeah, so some investigations to go through. So things like EEG. Again, buzzwordy things. So ADHD, you get frontal central slowing in the EEG. In depression, you get left-right asymmetry of prefrontal cortex. And under imaging, nowadays for like neuro stuff, the go-to imaging is MRI, just because it shows you your soft tissue a lot better. And MRI doesn't use any ionizing radiation as well. So what is one other condition that EEG is used for that I covered earlier on? Yeah, so like seizures and epilepsy. So dealing with emotions, just a quick run through because it's psych. So in angry patients, you can't be intimidated. So ensure privacy, offer the patient like water and everything. Yeah, so like this year, I actually met like a really angry patient who just kind of like walked out of the room. But I think the most important thing is just to be really calm and just make sure that you're professional and everything. And in the OSCEs, if the patient is angry, usually there's like a trigger thing. So like sitting down and offering the patient a seat will usually calm the patient down and just saying sorry. Yeah. And when we were first years, we had a depressed patient, and the patient was just crying the whole time. So I think importantly, just offer the patient tissue, and usually, yeah, just say like, I can see you're visibly upset. Would you like a tissue? And hand the person a tissue, and try to be a little bit more genuine. Yeah. Okay, so sleep, it comes out like 1 or 2 questions in your thing. So just know that REM sleep aids learning consolidation, whereas non-REM sleep doesn't. It's more for like repair of injury. So investigations, again, you don't really need to know in detail. I'll cover this when I talk about OSA. So sleep apnea. So someone want to tell me what apnea is? What about hypopnea? Yep, so overly shallow breathing. And sleep apnea is basically sleep disorder characterized by periods of apnea or hypopnea during sleep. And AHI, you don't have to know this, just good to know. And there are 2 types of sleep apnea, obstructive and central. And I think you guys had like a PBL on obstructive sleep apnea. So fair game if they give it to you for OSCEs. So pathophys, usually it's due to like anatomy, so collapse of your airway during sleep, causing like reduced or complete sensation of airflow. Risk factors, if patients are born with like craniofacial like abnormalities, usually obese patients have it. It's really common. A lot of like the big blokes in hospital have it as well. Non-modifiable things, so males tend to get it a lot more than females, and it's also associated with comorbidities like CVS. So cardinal features are basically things for you to ask the patient when taking a history. Importantly would be like your daytime symptoms, so things like daytime sleepiness, fatigue, and morning headaches. So does anyone know why patients with OSA get morning headaches? Yeah, so what happens when you don't breathe properly at night? It's actually because of hypocapnia. So like too much carbon dioxide in them. Yeah, because you're not getting rid of it. But yeah, good guess. Investigations, first line, polysomnography. The Epworth Sleepiness Scale basically quantifies OSA but doesn't diagnose it, so just good to know again. Management-wise, medically use CPAP to help them breathe at night. Do you guys know the difference between CPAP and BiPAP? So CPAP is continuous, it's a one-way pressure. BiPAP has both inspiratory and expiratory pressure. It's more commonly used in patients with respiratory diseases which aren't OSA, so things like COPD and stuff. Okay? So another thing they might use CPAP for is when a patient has like acute heart failure. And complications again, heart failure, arrhythmias, because of the constant activation of your SNS at night. And like monitors likes you to know all the social stuff, so like workplace accidents and car accidents. And again, you need to know what happens to drivers with OSA. And CSA, nothing much to evaluate. Just know that, just recognize that like chain stalks breathing is basically waxing and waning of ventilation. Again, buzzwords. So insomnia is basically when the patient complains of difficulty with sleeping. So it can be either due to the fact that they can't initiate sleep or they can't maintain a good sleep throughout the night as well. And again, management would be to treat underlying causes, give them like cognitive behavior therapy, sleep hygiene, so get them to keep like a sleep diary, download a sleep app to like track their sleep, or like dim the lights at night as well. And occasionally you give them medications, but generally not recommended. So not very important, just basic points to remember. I'm not really gonna go through this. And this is not important as well, but I just put it in for you, like completeness sake. This is important to know. So delayed sleep phase syndrome is like all of you guys, late to bed, late to rise, and then advanced sleep is the opposite. So like old people, they sleep at like 8 and they wake up like 6 a.m. in the morning. And basically management is to make sure that there's an appropriate sleep environment. Okay, so this question is a favorite with the faculty. You guys have to know it. So what is the answer? Just saying, but Flux actually works. I used it last year for my fires. Like I downloaded it, and then like at like 11 o'clock, it'll like dim my computer screen, and then I'll get really sleepy, and it forced me to sleep. So yeah, download it. It's good. So the answer is E. Has everyone gotten it down? Yep. Okay. Next question.
Sorry, Sarah, what was the answer?
The answer is E. We're almost there, guys. Last 3 slides. So which of the following regarding REM sleep is incorrect?
Sorry. So,
Yeah.
last question, was it A or E?
E.
Yeah.
Oh, this one's tricky. Any guesses? Sorry? Yeah. No. It's E. Do you guys know why? Okay, because during REM sleep, you get relaxation of your skeletal muscles. So what are some of your accessory respiratory muscles? Yeah, so like things like your intercostals, like your SCM and your trapezius are all accessory muscles. So are they skeletal or are they smooth muscles? Yeah, so if REM sleep causes relaxation of skeletal muscles, so A is wrong because like it says you're contracting. Yeah. And usually the patient gets a little bit of hypoventilation, but the patient can still breathe because the diaphragm is working really well. And last question, I think. Oh no, second last question. Someone just shout out like an answer. Okay, we'll go through them. Do you think snoring increases the risk of OSA? So it's counterintuitive. The answer is no. At birth sleepiness scale, it's actually a screening tool. It's not a diagnostic thing. CPAP is commonly used in patients with OSA. What is BiPAP used for? Yep, okay. And patients with OSA may present with chest palpitations. Do you guys think this is right or wrong? Yep, that's right, because patients with OSA tend to get arrhythmias. And no, postmenopausal women don't snore more than men do. Men snore more. And yeah, so that's the end of it. And yeah, so the first line drug should be right, because I got them off ETG, which is like this amazing like Australian drug thing that you'll use next year. And yeah, that's all, guys. Good luck. And if you guys have like any questions, I'm more than happy to take them. Yeah.